Hello, I want to welcome you back to our endocrine system series, and today we are going to look at the part 5, the insulin hormone and its effect in the body and the other details. Once again, I'm Mellitus Caroline. I want to thank you for subscribing. Please stick with me as we learn together small steps that matter in our academics. So, insulin. What is this hormone that you've heard several times? Insulin is a peptide hormone secreted by the beta cells of the pancreatic islets of Langerhans, and this is responsible for maintaining a normal blood glucose levels by facilitating cellular glucose uptake and regulating the carbohydrate, lipid, and protein metabolism. So literally, the insulin, it's like the key that opens the cell for the glucose to enter. So without this key, the glucose is unable to get into the cell so that it's utilized. So let's basically look at the major insulin functions. 1, it increases entry of glucose into the muscles and the adipose tissue. 2, increases liver glycogenesis. Genesis is usually formation. So the formation of glycogen, a primary carbohydrate stored in the liver and muscle cells of animals from glucose, and also increases liver glycolysis, which is glucose metabolism. Insulin also increases lipid synthesis. So literally what lipid does is to make sure that it removes glucose from saturation. In whatever way it has to do that, it will do it. Whether it's forming lipids, whether it's changing it into other forms of protective nutrients, that's what it will do. If it means preventing the lipids from breaking down that will form the glucose, the insulin will do that. So in whatever way it can reduce the glucose in blood, it will function that way. So insulin also inhibits glucose production by the liver. It also stimulates protein synthesis and inhibits its breakdown, because the more you form proteins, the less glucose that you have. And also it inhibiting its breakdown, it means we are creating less of the available glucose in blood. So before we go to any other thing like management, we need to note the normal blood glucose levels. 1, the expected values of normal fasting blood glucose level concentrations are between 70 to 100 milligrams per deciliter, or between 3.9 to 5.6 milligrams millimoles per liter. So whenever you go beyond that in a patient who is diabetic or who is not known to be diabetic, you need to start questioning the functionality of the insulin hormone. So there is also another test called the HbA1c, which tests the amount of the glucose molecules that have been bound to the hemoglobin, and these tests will help us know how much glucose is being regulated by your body in a period of 3 months. Whereas the random blood glucose level is instant, it will tell you what the body is doing to the glucose at that point. The HbA1c will be able to tell you what the body has been doing with its glucose for a period of 2 to 3 months. So this is a long-term measurement. So we go to our main things. If we don't have enough insulin, we get a condition that we all know called diabetes mellitus, or shortened as DM. And if we have too much, we get hypoglycemia. That's a major complication that if you don't manage these people so well, or if you give them too much insulin, you're easily going to get into hypoglycemia. So let's look at diabetes mellitus. So we have majorly 2 types of diabetes mellitus. There are some other subtypes that I'm not here to discuss at large. So here I'll be basically looking at type 1 and type 2 of diabetes mellitus. So the type 1 diabetes is an autoimmune disorder, and it's usually caused by unknown sources. So the cause is usually idiopathic. So in some cases, the body has destroyed the beta cells in the pancreas, so there is no place where we can form the insulin. Or sometimes due to the lack of insulin, no glucose can get to the cells for the metabolism, and that's majorly in type 1. Whereas in type 2, like we'll be seeing in the next presentation, there could be some insulin, but it's not as good, it's not good insulin, or it's not adequate to cause the glucose to enter the cells. So when the glucose is unable to enter into the cells for metabolism, it leads to uncontrolled high levels of glucose in blood. And this type 1 diabetes mellitus is very common in children, and sometimes it's known as the diabetes of children. Okay, it's also known as the insulin dependent diabetes. Literally, these people would depend on insulin for the rest of their lives because their body is not making any kind of insulin. So what assessment findings will you get in a person who has diabetes? These signs and symptoms are common for both type 1 and type 2 because at the end of it, both type 1 and type 2, we are unable to control the glucose levels that are in blood. So we'll present with similar symptoms. The only difference could be in the age. The other one is in among children, while this one affects majorly the old. So let's note the 3 P's. There is polydipsia, which is excessive drinking. There is polyphagia, which is excessive eating. There is polyuria, which is excessive urination. Those are very characteristic of DM. Also, we have fatigue, we have irritability, we have headaches, we have hyperglycemia, we have syncope, and also blood vision. It's very important to manage type 1 diabetes because literally these people depend on insulin for the rest of their lives. We might play around with their diet, we might play around with their exercise, but we never play around with the insulin administration in a type 1 diabetes patient because their body is literally not making the insulin. So you need to supplement or help the body make this, use this insulin. So here we majorly look at the types of insulin. These have different peaks, just like the names show. Fast acting, short acting, intermediate acting, long acting. The more down that you go, the longer the peaking time. So you need to make sure that when you're giving a fast acting insulin, make sure the patient already is eating or they have their food there because it will peak when the food is not yet on the ward and this person will run into hypo. For example, if the patient is going to bed, it's not advisable for you to give a fast-acting insulin because by the time it peaks, this patient will be deep asleep and they might easily pass out or die in their sleep because there will be no one to check their insulin levels. So it will be best to know their peaks, knowing that long-acting is the best insulin that you can give before a patient goes to bed because it doesn't have any peaking time and it can take so much before hypoglycemia can set in. The other thing I also need you to note about the types of insulin is that the regular insulin is the only insulin that's given by drip, that's given intravenously, and it's usually clear. This regular insulin is also a short-acting insulin, and it can also be mixed with the intermediate acting insulins. And the order of mixing, just like the name, regular and then NPH. NPH is an intermediate acting. So the order of giving should be in when mixing, you should withdraw the regular before you withdraw the NPH. RN. We are all struggling to pass our exams so that we are registered nurses. So that's how I remember the order, RN. So you first withdraw the regular before you withdraw the NPH before giving it. The other management of type 1 diabetes is diet. Diet is very important in diabetes management, because whatever you take in is what is going to increase your sugar levels. So you need to teach these people on how to manage their diet. Exercise is very important, but not as important as insulin administration in a type 1 diabetes. While you may teach them how to exercise, teach them the best times of exercise when they've already measured their blood glucose levels, when it's at the peak, and when they feel like they're running into hypoglycemia, they need to stop. You should also advise them that whenever you're exercising, you need to take periods of rest and also carry a snack with you. So I would like to take you through the complications of the major complication of type 1 diabetes mellitus, and this is something that you interface with in your practice. It's very common and it's easily diagnosed because the symptoms are very clear. But first and foremost, we need to understand how does this exactly happen. So I'm going to summarize this in a few sentences. One, there is no insulin to carry the glucose to the cells. Like I've said, in type 1, the body is not making the insulin. So if there is no insulin, the glucose levels are going to be high, but then the cells are not receiving that glucose, because the insulin, like I said, is the key to the cell. So without the key opening, the glucose will not enter into the cells. So what happens? The glucose builds up in the blood to more than the normal concentrations, causing hyperglycemia. So blood becomes very hypertonic. Hypertonic is having a higher concentration than normal. So this stimulates the thirst centers in the hypothalamus, causing polydipsia, because we said the osmoreceptors are very sensitive. Whenever they sense any change in the concentrations in the blood, the thirst centers are very stimulated, causing excessive drinking. So also the hyperglycemia will cause a fluid shift from the intracellular compartment to the vascular compartment, causing dehydration of the cells, because the blood is more concentrated. It draws the fluid out of the cells, leaving the cells dried up, while there is fluid build up into the vascular compartment. So due to the fluid shift, the kidneys will work hard to filter the excessive fluid and glucose, causing polyuria and glucosuria. Glucosuria is the passing of glucose in urine. Since the cells are not receiving the glucose, it means they are starving. And so the body senses that and stimulates your brain so that you eat more, because your body is literally, your cells are starving. So your brain is telling you, I'm not feeding enough, there is not enough glucose within me. So while the glucose is too high in the blood, the cells are not getting it. So you continue feeling hungry, hence the eating. So in compensation, as the cells run out of glucose for metabolism, they resort to protein and fat breakdown, hence producing ketones. When these ketones get into the blood, they cause acidosis. That's why we find that in DKA, because the body has resorted to using fats as a source of energy, we get ketoacidosis. These people present with symptoms of acidosis. So the kidneys will increase bicarbonate production to neutralize this acid, the ketones, the acidic ketones in the blood. So every organ is trying its level best. The blood is acidic. The kidneys are trying their best. They will try to increase the production of bicarbonate. They will also prevent its loss through urination because they want to neutralize this acid. While the lungs, since the blood is very acidic, there'll be so much fast and deep breathing, which is also known as the Kussmaul breathing, because we want to blow off that acid in form of carbon dioxide. So when you notice Kussmaul breathing, know that there's something in a diabetes patient. Know there's something wrong. Know that there's something wrong and you need to act immediately. So when you notice all these symptoms, we've talked about the polyuria, we've talked about the polydipsia, we've talked about the ketones in blood, the acidosis, the Kussmaul breathing. When you put your picture together and you realize this could be DKA, this is an emergency. Don't even think twice. Don't even say, let me continue monitoring. You need to act immediately. You need to act and do the necessary management as a nurse. So, let's summarize our DKA, the signs and symptoms in DKA. Everything is in the name. And here I have 1D in symptoms, 3 Ks and 3 As. The first D is dehydration. These patients, like I said, there was a fluid shift from the cells into the vascular compartment. So the cells are dehydrated. These patients will present with signs and symptoms of dehydration. 2, the Kussmaul breathing. There is deep and fast breathing because we want to expel the carbon dioxide to reduce the acidosis. There is also an increase in potassium ions in blood, causing hyperkalemia. There is ketones in blood due to the fat metabolism. These patients, as they are trying to excrete the ketones through the saliva or through their breath, they will have these acetone breaths. It's a fruity smelling breath. They will also present with acidosis because of the ketones and then anorexia. Still, these are signs and symptoms that are caused by the excessive ketones. So, we summarize DKA into dehydration, 3 Ks, Kussmaul breathing, the K ions, the ketones. Then A is the acetone breath, acidosis, and anorexia. Then other assessment findings, like we had discussed earlier, we'll have that. Majorly, how do we manage someone with DKA? So they are suffering all these things because they don't have insulin. So the first thing you need to think about is administer insulin intravenously. And here the best choice in this situation, because it's an emergency, is the fast acting insulin, which goes into the drip and it will act so fast. So our main aim is to lower the blood glucose levels. So insulin will do that, but it will also help in increasing the cellular uptake of the potassium ions. Where blood glucose goes, even the potassium goes because of the insulin. The other management is to monitor the blood glucose levels very closely, because we need to know, is the patient improving? Do we need to add some more insulin? Do we need to increase something? So you need to monitor this patient's blood glucose very closely. 3, these patients are very dehydrated and their blood is very concentrated. So resuscitate them with so much fluids as much as you can as you're monitoring their input and their output. If their random blood glucose levels was too high, for example, more than 300, for example, and then as you're monitoring it, it lowers to around 250 during insulin administration, you may need to give these patients a D5 fluid, because while you're giving this insulin, it's also at risk of causing rebound hypoglycemia. So to prevent that, we can secure by giving them some D5. And then you need to monitor ABCs, because this DKA affects A, B, and C: airway, breathing, and saturation. So you need to monitor and attend to these patients accordingly. You need to monitor your electrolytes. For example, we said in DKA, the potassium ions are well elevated. So if you're not monitoring this, the patient will suffer because of the increased potassium ions. Their respiratory system could shut down. They could have arrhythmias because of this change in potassium ion. So you need to monitor your electrolytes and act accordingly. So again, I want to thank you for listening. I want to thank you for sticking with me. Life in Nance Carol. We'll be looking at type 2 diabetes and its details and its management. Let's learn together. Watch, like, and share. Don't forget to subscribe. Again, I want to thank everyone who has subscribed. Life in Nance Carol. I love you all. Stay blessed.